This week on the BackTable podcast.
You can walk into a case and you've thought about an approach one way because that's the way you usually do it, or that's the way you did it the last time and it went well. Throw some AI onto this, right? Where now we pump in all of Raj's cases for liver ablation. And what if the machine, the robot says, can I suggest an alternative? Here are 3 different approaches that you could take for this case. And based on 1,000 cases, this is probably the best one for you. Like, that to me is super powerful and exciting. You know, that's down the road, right? And, you know, the ability to say, you're going to hit this rib, or in these last 100 cases, if you went this approach, for whatever reason, there's more pneumothoraces. Like, so using the power of AI and big data, behind all of this is only going to make us better.
Hello, everyone, and welcome to the BackTable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on BackTable.com.
Today's podcast is brought to you by the team at Quantum Surgical. They've developed the Epione platform, a state-of-the-art system designed for robotic-assisted percutaneous ablations. Epione is designed to strategically solve IO program challenges in the following ways. Epione standardizes workflows by simplifying the procedural process and may increase needle placement accuracy with a single push from skin to target. Fewer required scans during needle insertion may limit radiation exposure to the physician and patient. Epione enables physicians to treat complex and difficult-to-access tumors, ultimately increasing patient eligibility. It is easy to use, with a short learning curve that enables physicians to maximize efficiency and train less experienced users. This all-in-one solution streamlines implementation and enhances procedural consistency by enabling users to plan, target, deliver, and confirm within a single integrated workflow. Epione is FDA cleared for CT-guided percutaneous ablation procedures in the abdomen. For more information, visit quantumsurgical.com.
This is your host, Jacob Fleming. Today, we are diving into the topic of robotics and interventional radiology, and have 2 luminaries in the field of interventional radiology and interventional oncology. I have Dr. Raj Narayanan from MCVI and Dr. Sean Tutton from UCSD, formerly MCW. And Dr. Tutton, of course, this is your return visitor to the show. Welcome back. Dr. Narayanan, thanks for your time. Welcome to the show. Welcome to the BackTable community, as it were.
Hey, thank you, Jacob. Thank you for having me.
Yeah, glad to be back.
It's great to have you. And this is a topic that, as people who've listened to the show know, I've been very excited about, kind of nerded out at many different points. And also having had a chance to see the Epione robot in a few conventions, I've just been so fascinated with this. And so I really appreciate you both coming on the show. It's been a work in progress, and finally we've gotten the stars to align. And so we'll just jump in, and I'd like to hear about each of your experience. What was your introduction to the robot, and what was the use case in your practice? How did you start? And let's go from there. So Dr. Narayanan, if you'd like to start.
Sure. Thanks, Jacob. So just like you, I've seen Epione, or I used to see Epione in different trade shows and different conferences, but never really got interested or intrigued by it at that time, because like many ablationists or those who do ablations, the first thing that comes to your mind is, why would I need that? Because this is something that we do routinely. And then that slowly changed one day when I had a conversation with Professor Thierry Debert from France. Thierry is renowned in the world of interventional oncology, does not need an introduction. And he had done a lot of the work on the technology from bench to animal experiments to then taking it to the clinical space. And we had quite a long chat about it and his experience. And that really got me interested and intrigued. And I wanted to then see what we could do with that in our practice. And so that's how we got started. And it came at a kind of a crucial time for our practice, because our ablation practice had gotten really busy and we kind of maxed out the number of patients we could do in the room. And we were looking for areas where we could improve our efficiencies and see if we could treat more patients in a timely fashion. And this kind of coincided with that time. So that's where we got started. And currently, we started with liver ablations with microwave, single probe microwave ablations, and then slowly moved on to multineedle cryo. And we're a busy IRE practice, so we do several multineedle IREs with it. So we've kind of used it for all three energies.
Fantastic. And having seen some of those images of the IRE probe placements, it's really quite amazing how precise the technology is with this. And Dr. Tutton, why don't you tell us a little bit about the practice at UCSD?
Sure. So, similar to what you've both said, just the concept of robotics made sense to me in the IR space. And I think that if you look at the surgical space, it's been well established in spine interventions and spine surgery, as the Da Vinci and all these different things. So for some of the more challenging liver ablations, the multi-probe, big desmoid tumors, and then for my own unique practice where we're collaborating with the orthopedic surgeons and doing ablations and putting screws and cement and these new balloons in the pelvis, that's at minimum 3 access points, and at least one of those access points is in the plane of the table. So, kind of running along the plane of the table. And so it's impossible to get the II, imaging chain to be so, down the barrel or sort of in a bullseye mode. And so that one was always very frustrating. And so when I saw the robot just sort of drive right to that position in less than a couple of seconds at the trade show, I said, we have to try this. So that's really been the genesis of bringing it into our practice. Plus, as I think, just as with Raj's practice, patients really gravitate towards robotic guided procedures. And I think that there's at least a perception there that it adds accuracy, efficiency, and safety. And so I think as a big institution, we wanted to vet that in the IR space. And I know that Raj has the same sort of feelings about that. So that was the genesis of it.
Fantastic. And I love that you talk about the hardware perspective. Of course, that's my own personal interest as well. And I think what you just talked about access points being in the plane of the table and things like this, very just kind of extreme things. What I like about this technology is it allows us to think about problems a bit differently. Whereas I would say, I feel very comfortable doing a lot of CT guidance cases, but you become used to this idea that you're sort of locked in the axial plane. And then, of course, certain areas will use maybe an ultrasound to kind of facilitate access and get a little multimodal. And so we're used to thinking outside of the box, but I feel like this adds a totally different dimension for cross-sectional guidance. And on that note, so this has predominantly been used with CT. And so both your institutions, of course, are world-class hospitals and have the best imaging capability. And so some people, of course, nowadays have sort of the angio-CT sort of combo system. I'm wondering, has your experience been solely in the CT suite or any other type of modality such as cone beam CT?
My experience has been only in CT.
So just because I am always kind of thinking about where can we take this technology, I have been migrating out of the CT environment to the cone beam CT environment because of the access to the patient, the fact that when you're in an angio suite with cone beam CT, you're with your IR techs and your IR nurses, and everybody on the team is very comfortable with IR work and IO work. And so I've actually, even before the adoption of the robot into the workflow, had been moving ablations out of CT into cone beam CT. And I think it's an interesting, if you allow me just 1 minute, when we first started doing these CT guided procedures, just as you said, Jacob, axial plane, and if you had tilt the gantry, you'd tilt the gantry so that you would stay in the axial plane to the needle. And I remember when we were purchasing our new CT scanner and it didn't rotate the gantry, you couldn't actually get the gantry to tilt. I said, well, that's nutso. Like, I can't function this way. And they said, well, wait till you see the multiplanar reformats. You're actually going to change your thinking about this. And sure enough, as soon as I had tableside control multiplanar reformats, I never tilted the gantry again. And so similarly, when you start doing some of these tougher ablations, lots of probes, or we're putting screws in and you're in a CT environment, it's just very constraining, very tough. And so moving to this cone beam CT environment made a lot of sense to me. And so we've done a number of those cases, albeit off-label. And we started with some real layups and making sure that we were safe. And we've done some bone cases and we've done some other cases in the cone beam CT environment. And it's perfectly, it's a perfect adaptation to have the robot married to the angio suite with the cone beam CT.
Fantastic. And I'm glad to hear both of your different perspectives with this. Raj, can you tell us a little bit about your experience integrating it into the interventional CT suite?
Sure. It was kind of a seamless integration, mainly with the help from the team from Quantum. They've been really good in supporting us, and right from day one till now, we have clinical support for every case. So the way we kind of brought it into the workflow was that the robotic workstation and the arm is set up in the room before we actually get in, and then the patient is brought in after that. And then once the patient is intubated and under general anesthesia, then we do the usual scans. In my practice, we use contrast as if in every patient as long as renal function allows it. And then what changed in the workflow is that rather than planning your axis or where you're going to place your needles on the CT console, now everything is transferred to the workstation of the Epion robotics system. And then then you go into the CT room and then use that workstation to plan your trajectories. And as both of you just mentioned, the advantage of having all three planes available to you with your stock scan, if I can call it, your regular axial scan. Otherwise, we would be using the CT console. But now on the workstation, you can see axial, coronal, and sagittal. And then it also gives you a rotational 3D view if you want to spin the whole thing. And then now you can plan your trajectories. And then after that, that's transmitted to the robotic system. And then when you're ready to go, you have the patient apnea and then start placing your probes.
Beautiful. And I have to ask, before I forget, this will keep me up at night. What do you do with the robot when it's not in use? Does it sit in the corner, sadly, until it's summoned, like most of these robots do?
In our practice, we have a room we call the toy store, so it gets moved to that room, and that's where all the toys are.
Sean, how about you?
Yes, it sits in a storage area, but if we could, get it to make popcorn or cut hair on the side or something like that, you saw the Tesla, like there's a video going around of the robot cutting Elon Musk's hair. And so maybe we need to figure out some other tasks for it to do in its spare time when we're not using it.
Okay, quantum surgical engineers, you heard it here first.
Yes.
Popcorn maker or barber will be good for the next firmware update.
Mixed drinks, I don't know.
So we've talked a little bit about the logistics, and I'm sure some of the audience is wondering at this point, okay, well, you talked about how you have this thing in the room and you do a CT or a cone beam CT. How does this actually work? What makes this magic? Because there's some additional kind of logistical process that goes into the three-dimensional CT reconstructions actually being usable.
You mean, how does the actual robot works?
Exactly, and the way that the robot knows what point is where on the patient. This is something that it's interesting to me that other specialties like neurosurgery and orthopedics have been using navigation like this for quite some time, and yet in IR, where we're used to using so-called advanced modalities, this is something that's mostly totally new to us.
So I'll try to explain it the best way I could. So there's a camera, it's a camera-based system. So there is a camera that is used on a separate stand, which has to get a view of the robotic arm, and also the patient reference, as it's called, which is a ring with some sensors on it, and that is attached to the patient's abdomen. Typically we try to place it on the side opposite to where we think we're going to access the patient's organ. And then once that patient reference is taped in, there are also 3 to 4 little baby markers that are placed on the patient's skin. And those are used with another handheld device, which has the same sensors that you have on the robotic arm and in the patient reference. And that is used to touch these BB markers to ensure accuracy. And once that's done, then you've completed the accuracy test. And then now what you have to do is make sure that the camera is able to capture both the patient reference and the robotic arm. So there are icons on the workstation, and both of them have their little images there. And if the camera is not able to sense it, it's going to have a red check next to it. And when the camera is able to see it, it becomes green. So once you have both of them in view, then you're ready to get started. And at that point, we need to pick the angle with which the arm is going to travel to get to your destination. So that's where the role of the clinical specialist comes in. So they are able to look at where we're going to go and make a guesstimate of which angle to use. Vast majority of the time, it's just a one-time thing. And sometimes we might have to play with 2 or 3 angles to make sure that the robotic arm gets into the right position. So we typically do a dry run to make sure that, the arm gets to the right position. And then once we feel comfortable that there's nothing in the way, then the robotic arm goes back to a neutral position. Anesthesia places the patient in apnea. And then we hit the pedal once the patient is in apnea, and the robotic arm gets to the right place where you're supposed to place the probe. And this is when we pretty much use the probe, push the probe from the skin to target with a single push. In the beginning, we used to use a scalpel to make a skin nick before we push the probe in. We then found that it's easier to use a Murphy needle or a coaxial needle through the arm, and that first makes a track. And we not only go through the skin, let's say we're ablating the liver, we go a little bit into the liver, but the Murphy, we take that out, and then we push the whatever device we're using, microwave or cryo, with a single push, and then you release the robotic arm, and then when you press the pedal, it moves out of your way. And then now you can either do a check scan, or when you get more comfortable, you can place 2 or 3 needles and then do 1 check scan. So that's kind of the rough workflow of what happens.
That was fascinating, and thank you for that. Was a very vivid description. And one thing I'd really like to think about is kind of the actual practical ramifications of this. And I've been very impressed seeing the demos in conventions. But just to give our audience an idea, can you tell us, for after you've kind of gone through this dry run for the actual placement of a probe, about how long does that typically take?
So everything is done in a single breath. So to give you an idea, when the patient goes into apnea, so from the time the patient's in apnea, the robotic arm moves into place, you open the clasp, you place the Murphy, take it out and place the microwave probe. So if everything is done, just in one sequence, I would say the whole time for everything is about a minute or a little over a minute, tops maybe a minute and 10 seconds. And that's to get your probe right to the destination.
That's incredible. Just for so many experience I'm sure we've all had, trying to do a lung biopsy and under moderate sedation and trying to skewer a lesion often takes much more than a minute total. So that's fascinating. Sean, I'd like to ask you, as we talk about the access and how smooth this is, you're using probably some implements that are a little bit bigger than Raj's in terms of the more orthopedic type of approaches. I'm curious, can you talk about your access approach? Are you still making a skin nick most of the time?
So the way that Raj described it is similar to how we approach, our soft tissue ablations, be it liver, kidney, lung. And I think that the aha moment that you have as you work with the robot is, as Raj alluded to, is that you're much more confident about just putting the needle in. Like you just drive it in, and because it knows the depth. And as long as you've drawn your path and it's not going to, hit a rib or some other harder structure, it's just going to go straight in. And then you're going to take your confirmation scan and it's going to be highly accurate and right where it needs to be. Whereas, in the previous workflow, you kind of inch your way forward. And the younger you are and the earlier you are, the more inching, right? And the more time that takes and the more scans it takes and just all of that. So that is, I think, the big aha for me with respect to the ortho work that we do, which is just again, 11, 10, sometimes 8 gauge needles. What we have done is, the nice thing about this system is it is fairly robust and it will handle these larger needles, and you can actually tap the needles through the arm. And so to seed it into the bone, which is one method. What we're evolving to is actually using these larger needles to bring it down and put it up against the bone. So it's resting against the bone, take the stylet out so that you now have a working cannula through the tissue, right? So it's a tissue sleeve that you've created. So kind of like what Raj described with the Murphy needle and sort of creating a path, we take a large bore needle, create this tissue sleeve, and then drive a guide pin through that while the robot is kind of holding it in place. And that really allows you to engage the cortex of the bone, have it perfectly positioned and in the correct orientation, and then come through and drill through this tissue sleeve, if you can imagine that.
That's an amazing idea. I love that. It gets me thinking about a lot of the things that we do in the more interventional orthopedic work, if you will, involves a working channel, like you said, which
Bingo.
I think of it's just a variation of the vascular sheath for IR. So it's something but having this rigid access is so important. And a bit of a very specific nerd niche question here: are you using a beveled needle to access curved bones, or are you actually able to get in with a diamond tip? Because this is something that causes some consternation.
Yep. So, obviously it really depends on the sloping of the anatomy and what you're engaging. And so pedicles is sometimes you really do need a bevel and other times you need a diamond. I tend to go with diamond, and then I'll switch to bevel as my problem solving tool. And that's my personal workflow after, a couple of years. But once you because the diamond tip is sharp and you can bring it all the way down to the bone, and then you slide the cannula so that it's really up against the bone, right? And then the robot is holding it in place, which is really quite nice. And then you come through that with the drill.
That's very nice. One of the issues, of course, where we run into some injuries with these larger working cannulas is the soft tissue creep. So really nice having the robot being able to be your intern or your resident holding it in place. And on that note, of course, you both practice at world-class training institutions with well-known interventional radiology fellowship programs that produced some amazing people, many of whom have been on the show before. And so as you continue to train excellent interventional radiologists who are going to be practicing at the top of interventional oncology, how do you rectify this new technology that enables us to do different things, but it admittedly makes it a lot easier and almost certainly will not be what the trainees coming out will have available to use. And so I'm fascinated by this kind of dichotomy and this balancing act. I'd like you each to talk a little bit about how the integration has been into the training programs and how you see rectifying this as we mature in this space.
It's a great question. So in our practice, it was obviously that was one of the first questions that came to my mind. Once we start using the robot, doing a single push, how is that going to impact our trainees who are just starting and are still, the learning process? But fortunately, we do a whole bunch of biopsies and drainages where we do not use the robot, where they're still doing it manually and using their thinking in different planes to advance the needles. And we do pretty complex biopsies and drains. And so that helps in one part. But the second most important part to me is that IR has always been a specialty when generations before us. Change has been part of our DNA, and we've always looked at ways to make things better. And that's our DNA. We take complex problems and we simplify it, and we simplify it in such an elegant fashion. So it looks easy when we do it, but then there's a lot of thinking and engineering that has gone into it. And I give this example to some of my fellows where when I do a PTC or nephrostomy and I don't use an ultrasound, they look at me like, how is that possible? I've actually had these questions come to me, like, how do you know? And how do you get there? And I just trained about 2000. So the changes happen so rapidly now that without ultrasound, doing a PTC or a nephrostomy, or without using ultrasound to get an access, if you put your fingers and use the Scheldinger technique to get access, they look at you like, what are you doing? Is that safe? So that has become part of the culture of IR, and change happens. But we're kind of at the cusp now where you're in between two worlds. But what this would do, I don't think it's going to take away the ability of the IRs to think in different planes or to do complex stuff. What it would do, in my opinion, is it would democratize complex procedures being done in CT. As of now, the kind of ablation that we do in our practice is not something that people who do one a month or two a month would be comfortable doing it. But if this technology becomes more and more mainstream, then you can see more people and more patients getting access to minimally invasive treatment options, which otherwise would have to be filtered to bigger centers like Sean's or ours or whatever is the big university practice that happens to be in that particular town. Now, with the aid of the technology, even those who do not do this routinely can now take on complex procedures and offer that. So I feel that the benefit, like we say in our world, does the benefit outweigh the risk? I think in this particular case, it does.
Yeah, it's really interesting. And as I was thinking about bringing the robot into our practice, you think about the obvious, well, it'll make me faster, it'll make me more efficient, I'll be able to do more cases. The more subtle things that you realize as you start to work with it are that your intensity of your day. So if you have two back-to-back very difficult cases that you were going to do completely freehand, well, in those cases, you probably would elbow the resident out of the way. You might let them sort of get warmed up, maybe numb the skin, do some basics on the beginning, and then you're going to kind of shove them out of the way because it's such a hard case and you're worried about it. So, that's my internal barometer is if I'm freaking out about this case, it's difficult for me to let the resident do the majority of the case. The robot completely changes that game, right? So when you have a difficult dome liver ablation that you would have never let the resident tackle, you actually can let them tackle that because you draw the plan together and then you work through the steps that Raj described, and then the resident can do the majority of that work, which I think is really tremendous. And your brain, which was firing on 8 to 12 cylinders, depending on your vehicle, is no longer firing at 8 to 12 cylinders. It's a little bit more relaxed, and you're relaxed, so you have a little bit more capacity to teach. You have a little bit more tolerance, right? Because you're not getting frustrated because it's a difficult case. So there's all of these subtle things that I'm realizing that I think will allow us to let the residents do more, the planning and the tumor confirmation software that goes along with it, all of that really mental work and strategy is the part that really becomes the main aspects of the procedure, and the physicality of the physical work the robot's doing now. And, Raj talked about the democratization of all this. Obviously, people have looked at this as a huge opportunity, right? Department of Defense deploying, medical techs that can, get the patient teed up, and then the robot comes in play, and then Raj and I or our equivalents in the Army are sort of driving the robot remotely. Like there's some really cool opportunities to sort of democratize all of these different procedures across the world. But from a training perspective, I think we're, just as Raj said, we're at the cusp. And we will look back on this, and I think it'll be pretty humorous, is if you have to do a freehand difficult ablation, that's going to be really challenging, I think, for the future young interventionalists. And so just like all these lap chole guys that are going to go and gals that are going to go say, well, geez, I can't do it lap chole. I got to go find somebody who can actually do this open, right? It's going to be the same, in my opinion, where somebody's going to say, wait a minute, I don't get to use the robot. I actually have to do this by hand. We're going to get there, I think. It's going to be interesting.
It'll definitely be very interesting, but I love both of your perspectives on this, especially what you just talked about, Sean, about how it actually enhances probably the educational aspect of it, which is really, I mean, a lot of these ablations, the freehand ablations, I remember some of the more difficult cases I ever had to do in residency, and they can be very very frustrating. And when, like you said, Sean, when you're just worried about the case as the head physician, the primary operator, you kind of get tunnel vision, and then teaching becomes, a secondary thing to this. And so it seems like the educational aspect is very similar to kind of the visual aspect, like we talked about with tilting the gantry and then getting multiplanar reformats. And then now the way you're looking at it allows you to see things totally differently and not have to use all that brain power. In addition to the actual physicality of it, which you mentioned, does drain you. So I think your perspectives are very, very encouraging, should be encouraging for our listeners. And I think this is a conversation that's just beginning. And I'll look forward to 10 years from now talking to you too, and we can compare notes.
Yeah, hopefully I'll be on a sailboat and I'll do my podcast from a sailboat.
Oh yeah, you'll absolutely you'll just be tuning in from the Mediterranean somewhere.
No, the other part I just want to make a point is also when we're planning, right? I let our fellows do the planning first, and then I go in and take a look at it to make sure that everything looks okay, and if there's any modifications that need to be made. When we do things on the conventional CT console, most of the time you can, of course, ask your tech to give me a recon in SAG and coronal, but a lot of times you don't ask that. You just do it in one plane. More and more, you start looking, when you're planning things in all three planes, you can realize that, okay, when you look at this in coronal, there's a little bit of the lung in the way, which we thought was not there, and we didn't pay too much attention to it. So it's always there, all three planes, and then you make your adjustments. And the other thing is also the off-plane cases in ablation. Sean talked about the dome ablations, which is always something most people are not comfortable. Off-plane is a completely another different game, and unless you're somebody who does ablations routinely, doing cases off-plane can be quite a challenge. With this, it completely takes out all the complexity of it. You click on the target, you go to this slice where you want to enter, you click entry there, and then your off-plane trajectory is just in a second you get it. And then our trainees do off-plane ablations routinely now with a single push. And that's one of the areas where I think it really shines, and it's going to change the game, where you're not limited by your access or your fear of what would happen if I'm not able to get this to go off plane from one part to another.
So to just wax a little bit, I'll give a plug to SIO and the ACCLAIM trial, right? That's cruising along, and we'll finish that trial, and we hope and expect that trial is going to demonstrate that liver ablation and colorectal cancer really is the thing to do. It's the appropriate thing to do in these patients. And so that volume of patients is going to go way up, and the awareness is going to go way up. Doesn't require a transplant center, so it's going to be a procedure that's going to be asked for by the patients, by the referring docs all over the country, all over the world. So there will come a time where potentially Raj or myself is walking around and there's two machines running simultaneously, and there's two robots, and the trainees are in those rooms, and you're going back and forth and looking at the plans, and you're trying to be as efficient as possible because your volumes have gone up so much. And so I think that that's very exciting for me. The other thing that's very exciting is, to Raj's point about all this off-plane work, you can walk into a case and you've thought about it one way, and you've thought about an approach one way because that's the way you usually do it, or that's the way you did it the last time and it went well. Throw some AI onto this, right, where now we pump in all of Raj's cases for liver ablation, and let's see what if the machine, the robot, says, can I suggest an alternative? Here are 3 different approaches that you could take for this case. And based on 1,000 cases, this is probably the best one for you. Like, that to me is super powerful and exciting. That's down the road, right? And so, or, the ability to say, you're going to hit this rib, or in these last 100 cases, if you went this approach, for whatever reason, there's more pneumothoraces. Like, so using the power of AI and big data, behind all of this is only going to make us better.
That's fascinating to think about that extra layer and how the treatment decisions can be informed based on data and not just experience, which is, as we know, medicine and in particular our specialty is very experiential, which is how it should be. But when you get to the point of being able to learn from the best people doing it, you can see Dr. Tutton's profile, Dr. Narayanan's profile, and see their special moves, that really takes it to the next level in terms of, as we've talked about a few times, just changing the way we think about problems and moving away from dogma and having data that can say, no, you don't need to worry, about potential injury going through this area. Really fascinating. One thing you both talked about that I think is something that is probably at the top of people's minds is this issue of efficiency. And I'd like to hear about how has incorporating the robot enabled your volumes to accommodate the increasing patient demand.
So in our practice, like I said, mentioned, it came at a very interesting time. And so we initially brought the robot in on a 3-month trial. And the MCVI has always been one of the areas where cutting-edge technology is always welcomed, and it's also analyzed in a methodical fashion. And even without me being involved, our administration was taking a look at the time that was taken in the room to perform these procedures. Until then, we were allowed to do only one ablation per day because of the backlog of biopsies. And since general anesthesia, all of that takes time. By the end of the 3-month time, again, this was from our administrators, that we were told that our time for microwave ablations was half of what we used to. And they were actually pretty enthusiastic about supporting, bringing the technology in. Our COO was very supportive, and we were able to bring the technology in permanently. So that now to the point where we are allowed to do 2 ablations per day if we have to. And that has significantly improved the wait time for patients. Before, it used to be even up to 12 weeks, believe it or not, because that machine was our workhorse. And with the ablations, we would still do another 4 or 5 biopsies to follow. So it was a very busy room, and it was not possible to tie it down with 2 ablations. So patients had to wait longer. And to answer the question about the volumes, so we had grown exponentially year after year and kind of hit a peak at around 140 patients a year. That was the max. For 2 years in a row, that was the max we could do. And the year we bought the robot in, we immediately saw a bump, which was last year. We increased the number past 100, up more than 150. And this year we're on track to increase that even further. So same machine, same room, but we're able to do more cases.
We've seen similar efficiencies with the liver ablations. I think that the corollary to all of this is, if you're going to do some straightforward biopsy, it's not worth the cost and worth you're not going to save time and you're not going to save money. But if you can look at your weekly, monthly, or yearly ablations and see real volume increases, 10, 20, 30%, because you're cutting times off and you're able to do 1 extra a week, 2 extra a week, whatever it is, or 1 extra a day, then the cost analysis works and it makes sense. In the beginning, as you're learning and iterating, you're slow, and that's normal, and you're being cautious, and you're not trusting the robot until you start to see that it is doing exactly what it says it's going to do, and then you start to get more confident and you go faster, and then your times start to come down, and that's what we've seen. And in our ortho cases, specifically this, in the plane of the table ischial corridor, which is the most challenging for us to do, that is so fast now that I expect that the combination of increased efficiencies of time and decreased intensity of work, right, that mental work that's required, now that it's getting easier to do, I'm more apt to do 3 of those cases a day rather than 2 of those cases a day. So not only is it the time aspect, but you're not burnt out. You're not toast after 2 really tough ablations or screw fixation cases. So you're more fresh to be able to do that 3rd case. So that's kind of the one that I didn't expect. And it's this mental, emotional energy that you have left in the tank because the robot's making your life easier.
That's really interesting. There's this very real cognitive cost of complex treatment and really any degree of treatment at all. And I think we take that for granted. And I realize it, at the end of the day, realized it daily for about 6 years during residency and fellowship, just that feeling of coming home and just feeling that you've been totally mentally taxed out. And there's a period of time where you do want to do that. And that's in your training in the early years of your practice. But at a certain point, the work itself is so demanding, it keeps you from being able to be engaged in different things, whether that's at work or back at home. And that's especially true for these very physical type of orthopedic cases. And you mentioned the ischial corridor, which is a very tricky one. And aside from that, I wonder, have there been any kind of novel insights you've had specifically into the skeletal work that you've done?
Well, you plan everything out ahead of time, and you start to let the robot decide which is the most logical one to start with, because there's a certain ordering of how the needles are placed in multi-needle cases. And the robot mathematically figures that out so that you're not going to collide into previously placed needles or probes. And so some of that, which is experiential when you're doing it freehand, you realize, oh, shoot, I shouldn't have done that one. I should have done this one first, right? So the robot is doing some of that planning for you, which is kind of interesting. As far as, this isn't in a musculoskeletal case, but I have a kind of a cool story. So in our very first day, the quantum people were there and they said, you're going to do 1 or 2 cases and that'll be good. And so we did a liver, and then I think we did a kidney right after that, and we were just cruising along. And their support team was walking out the door, and we got this crazy add-on case of somebody with, a spina bifida who had a kidney in the pelvis from a congenital anomaly, and it was obstructed. And we needed to do a perc-nef of a kidney in the pelvis. And I said, let's use the robot. And sure enough, and so they had already walked out the door. They had to come back. And we did the 3rd case on the first day, right off the bat, day number 1. And we, from a posterior approach, like you're going to do a transgluteal drain, we did a perc-nef into a pelvic kidney. Wild case. And I said,
awesome.
There's no way we could have done this without the robot. And it was true. And it was 1 stick, first pass, just the wildest case. So,
that's awesome.
Not an MSK case, but I think really tells the power, shows the power of the robot.
I think so, especially for, kind of the bread and butter IR cases that we probably take for granted that, we're in a lot of those cases performing a life-saving intervention, but to us, it's just kind of the regular day-to-day work we do. The possibility to fundamentally change the way you look at something like that. I mean, like you described, and I love that. That's fantastic. Have you had any similar experiences, Raj?
Oh, I'm not as dramatic as what Sean said, but in my world, it was a gradual escalation of complexity cases, like what Sean mentioned. Initially, you go by. My whole trust was on Terry's experience, and when he said you can push it from skin to target, I did my first case pushing it from skin to target, and quantum people were surprised. They said he didn't want to check. I said, no, the better said it's going to go to the target. So, and sure enough, it was at the target, and we didn't have to make an adjustment. So that was the very first case. But as we kept progressing along, we did the cryo case, and IRE was the last one that I wanted to bring into the complex world of ablations. And there was a learning curve. It was different compared to cryo and microwave, where it would hit it out of the park every time. And you might have to make some minor depth or a tiny bit of lateral adjustment, but usually, a lot of times it was right there where you want it to go. With IRE, when I'm doing, and Sean mentioned this earlier, you are used to doing things a certain way, and for more than a decade, I'm used to doing it a certain way, and you always want to go on plane as much as you can when you're planning. And you realize that very quickly that it's going to give you, it has a multi-needle planner, where if you put a cursor in the middle of the tumor and click on it, and then pick in a drop-down menu the number of probes you want to use, it has different geometries that it's already programmed. And you click on it and it gives you the trajectory for all the probes in one click. And some of them may not look aesthetically as pretty as you would plan it or want to go in the same plane, but it's going to get you from skin to target, and it's going to do it with one click. So that's a new kind of concept that you need to wrap your head around it, especially for those who have been doing things a certain way. Now you're kind of changing how you behave it on how you're going to do it. And for me, it took me almost a year, and till this date, I still consider pancreatic IRE as one of the most complex ablations that I do. And like Sean mentioned, that procedure still gives me trepidations, and especially when I'm with the trainee and we have to do it together, because you don't have too much room for error there. You're a millimeter off, 2 millimeters off, you're going to go through the artery. And then, so there's a lot of things that have to go perfectly right with that. So that was the last frontier for me with the robot. And I finally did the first panc IRE case, and that particular case went like a charm. And to Sean's point, again, I would never do 2 pancreatic IREs in one day freehand, because that is definitely, in my world, the most draining procedure that I can do in an ablation. And I did 2 of them in one day, and both of them with the robot and with trainees. So the point I'm trying to make here is that exactly what he said, that you are able to handle complex cases and at the same time able to do more of them without that mental fatigue part. Have there been challenges and things that we had to learn along the way? Absolutely. So I don't want this to come across like, okay, every single case was a home run. When we found with IRE, if the rib is in the way, Sean mentioned that, any part of the body which could potentially cause a deflection is not a friend for the robot. You want to plan a nice smooth road for it from start to finish, and then it's going to take you to your destination. If you're doing IRE freehand, you can scrape along the rib and make adjustments and take your needle. This one does not like that. It wants a nice clean path to go. And then there's another maneuver called the axial mode, which I was not using initially, where the robot allows you, even though it's planned the depth, it now gives you the option of taking the robotic arm as close as possible to the skin to get the probe in a little bit, and then you can release the clasp and bring it back, and it would stop at the predetermined distance. And now you can push it with one push, so that you don't have a deflection when you're using a thin probe, what you get with IRE. It's a 19 gauge needle. So that took me a little time to implement routinely. And once we got that accuracy, because the IRE probes, if you don't use the axial mode and you're coming from a longer distance to the skin, there's a potential for deflection. So that's another thing we learned along the way. So there has been a learning curve, but now we're at a point where we feel very comfortable, and we've been, even when we were learning, we were using it in every case, but now we're comfortable in every ablation is done with.
Very exciting. This has been a fantastic conversation. I have a lot to be excited about personally, and I know that our audience is really going to enjoy hearing about this too, and especially coming from 2 giants in our field who have really helped push the specialty forward. I am running out of things that I wanted to talk about, have so much to think about, but I wanted to ask if either of you have anything else you'd like to discuss.
I would just say that, like all the technology that we embrace, you have to commit, and you have to iterate, and you have to learn what the shortcomings are. And I'm glad that Raj brought up, not every case is perfect, and we've had some failures, and that's okay. But you learn, and you also expand your mind and realize that there are other ways to do things, and that just makes you better as an interventionalist. And this is just another tool in our toolbox that I think makes us a really unique group of people, right? So we are image-guided interventionalists, and what sets us apart from, surgeons is this incredible understanding and utilization of ultrasound, CT, MR, cone beam CT, navigation, robotics, all of this. And now we're bringing all this to bear. It makes us such a powerful, field, and we have so much to offer the patients. So, to those that are sort of questioning whether this is worth the juice is worth the squeeze, so to speak, I think it is, because it really enhances and just augments your ability to do your work, and it helps you to think outside the box. but it also adds a certain amount of rigor, right? Accuracy and precision at the same time. So that's a beautiful thing, in my opinion.
Yep, agree with all that Sean said. In liver ablations especially, even though technologies in the ablation world have improved tremendously, even from when I started, my training was just out of ablation. And then quickly we got the early microwaves with those giant hose pipes from Tyco. And then we got cryo and IRE and now histotripsy. The technology with ablation has improved exponentially or tremendously over the last 2 decades. But if we look at the way we measured ablation success as IRs, we've been kind of rudimentary for the longest time, relying on contrast enhancement for enhancing tumors. And even for those that don't enhance, we kind of look at it and say, okay, did I think I got a margin or did not get a margin? So we were clearly relying on experience and going by those techniques rather than having a more futuristic way of looking at success. One of the things that got me interested in the robot was not just the robotic arm, but also the workflow and the software enhancements that come with it. The ability for you to look at your segment your tumor and also do your post-ablation and do an overlay of both and to see whether you got a margin or not. So again, that's something which we really don't think about much when we don't have that technology available to us. And over the last few years, we hear more and more from anyone who's very serious about ablation about the importance of margins. And there's several publications now and getting an A0 margin and trying to make sure that you cover the tumor. So to have a visual aid to help you with that, obviously it's going to be validated with more experience and publications that are going to keep coming out in this particular space. But for today, you have the ability to have a visual aid, which is incorporated within the same technology, and also has the ability to fuse MR images if you have difficulties, especially in the liver. A lot of times we're not able to visualize it on CT, and you either bring in ultrasound, but now you have one more step where you can bring the patient's MR and fuse it to at least kind of get an idea of where this potentially could be to help you with your treatment. So I'm sure with the new software upgrade that's coming very soon, there are going to be more enhancements, and this technology is going to continue to improve. And what Sean mentioned about AI, that's another huge step. I also envision a time when remote capabilities are going to be available with this technology. It was already available with another device, but that currently is not in the market. But to have the capability of doing procedures where you're not tied down by the availability of a physician in that particular floor or room in the same hospital or even a different hospital. So this is going to evolve, and we're at the beginning, early stages of this. And like any other technology, eventually we're going to get to a point where, like I mentioned, doing a PTC without ultrasound, it's going to be like you're doing an ablation without a robot. So it'll be interesting.
Great analogy.
A few years from now and talk about this.
Awesome. Yes, I look forward to talking about it on Sean's sailboat. And in 10 years, we'll see. I'm sure whatever actually ends up happening will be something completely unpredictable from how we've envisioned it. But that's part of the excitement of our field. So, gentlemen, thank you so much for your time. This has been an excellent discussion. I've really enjoyed hearing about all the ways that you've used this new technology, and hoping to get my hands on it myself at some point in the near future.
Thank you. Thank you, Jacob.
Thank you,
Sean.
Thank you. Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.